Good afternoon and welcome to today's Women's Health webinar, Addressing Chronic Conditions During Pregnancy and Postpartum to Improve Maternal Outcomes. My name is Iman and I am the Program Manager here at the National Healthy Start Association. So our agenda for the day, we'll go over some logistics about the National Healthy Start Association. We'll move into our presentation for the day. We'll have a Q&A section and then we'll close out. So just as a disclaimer, thank you again for joining this webinar today. And by joining, you have consented to being recorded with your camera on and your name on the screen, or your camera off and name appearing on the recording. If you decline consent, you may leave the session now and watch the recording later. NHSA may be interested in sharing excerpts of this recording in other media channels. If you're featured in an excerpt we'd like to share, we will contact you to request your permission prior to use. The opinions and content expressed in this presentation and on the following slides are solely those of the presenter and not necessarily endorsed or supported by the National Healthy Start Association, its board, staff, and its affiliated programs, partners, and services. So just some logistics for the day. There are two ways to listen to the audio: through your computer speakers or on the phone. We ask you to please not use both methods. In the chat box, feel free to add any questions or comments as we go along. And if you'd like to unmute at any time, just please use the raise your hand feature. So about the National Healthy Start Association, we provide advocacy for Healthy Start programs, training, technical assistance and capacity building, coaching and mentoring, developing and disseminating resources and tools. Our learning objectives for the day is to learn why addressing the chronic conditions of diabetes, hypertension, and overweight obesity during pregnancy and postpartum is important, to develop an understanding of how an integrated clinical community approach to disease management can help improve outcomes, and to explore strategies to address chronic conditions by implementing the AIM CCI maternal safety bundles. So we have two presenters for today. Our first presenter is going to be Susan Kendig, who is a board-certified women's health nurse practitioner and attorney with over 3 decades of experience in maternal health care as a healthcare provider, educator, and strategist. Her clinical practice and policy work is grounded in strong background in the intersection of clinical practice and community health. Throughout her career, Sue has worked to improve patient safety and quality care. Active in public service, she has held appointments to CMS Medicare Evidence Development and Coverage Advisory Committee. She is also a member of the Alliance for Innovation in Maternal Health Executive Committee, and she has significant experience in patient safety bundle development, serving as a co-lead in developing maternal safety bundles related to maternal mental health, postpartum, and women's health care. She serves on the NQF Perinatal and Women's Health Standing Committee, and she was a member of the NQF Measures Application Partnership, Medicaid Adult Work Group, and Social Determinants of Health Data Integration Work Group. In her home state of Missouri, she served as an appointee to the Missouri Commission on the Patient Safety, which led to the development of the Missouri Center for Patient Safety. Sue then worked for the center in achieving recognition as one of the first 10 federally listed patient safety organizations in the country. Sue is committed to the concepts of clinical and community integration as a tool to improve health outcomes and to optimize quality and equity in healthcare service delivery. To this end, she has provided technical assistance to integrated primary care, medical home, behavioral home health, and other value-based care initiatives. As a collective impact maternal and infant mortality reduction efforts in urban and rural communities, she is honored to support the AIM CCI team as their clinical community integration and patient safety implementation strategist. And we thank you again, Sue, for being our speaker today. We also have Dr. Saanie Sulley, who is a data manager with the AIM CCI project, providing data infrastructure and analytics support to participants in the project. He is a health informatician with experience in medicine, clinical decision support systems, healthcare data integration, and predictive modeling. His interests include utilizing healthcare data and improving health outcomes and gaining better understanding of care processes, health equity, social determinants of health, and improving access to maternal pediatric care through quality improvement in these areas. Saanie earned his PhD from Rutgers University in biomedical informatics and an MBA in healthcare management from Columbia Southern University. Thank you again, Dr. Sulley, for being here as well. And now I will hand it off to Dr. Saanie Sulley.
Sure. Hi, everyone, and good afternoon to you. Well, good morning and afternoon, depending on where you are. Today, one of the things that I think I would like to start by setting the stage to provide a brief understanding of why we decided to take this part from the perspective of the AIM CCI bundles. And also, while I'm speaking, I'll try to give you a little bit of an idea of our development process briefly. But in our processes, one of the things we wanted to do, or at least part of our program objective, is to ensure that everything we do is based on equity, but also it's data-driven. And what do we mean by data-driven? We mean that we hope the data will inform the work that we do, but also what we develop from beginning is based on the evidence of the need. So I'm sure you know, as part of a general maternal advocacy around the country, that maternal mortality has been an issue that is of an urgent need. And I think the White House has an initiative, and several federal agencies also have initiatives aimed at increasing the awareness surrounding the concept of maternal mortality. But oftentimes, the issue that we don't hear probably as much as we should is the concept of maternal morbidity or severe maternal morbidity. Now, at AIM CCI, we believe that addressing maternal morbidity or severe maternal morbidity will aid in addressing maternal mortality, and therefore our focus is looking at the factors that contribute to maternal morbidity before we get to the discussion of mortality, because when we address these things or these factors, we will be hopefully able to eliminate mortality. So again, what is severe maternal morbidity? Severe maternal morbidity is a broad definition that includes all obstetric complications that could, one way or the other, impact the outcome of pregnancy. Now, again, several factors contribute to this presentation, including social determinants of health. For the purposes of what I am about to tell you, I will focus only on a very small aspect of it, which is chronic conditions, specifically hypertension and diabetes. Now, gestational hypertension and diabetes, as you know, complicates both maternal and neonatal outcomes, and that directly or indirectly impacts the overall outcome of care that is provided to mother as well as the child. Now, I'm also confident that you may have heard by now the racial and ethnic disparities that exist within the global outcomes of both maternal mortality and severe maternal morbidity, with ethnic minorities being more susceptible to these presentations across the board. And also, depending on what the type of data you're looking at, you will also be able to see both economic and also rural-urban differences in these presentations. Now, as we were thinking about the development, we wanted to be able to understand the relationship in which these comorbidities, specifically diabetes and hypertension, as well as obesity, contribute to this presentation based on these social and demographic factors. Now, again, this is not necessarily, we are calling it a study here, but it was not necessarily a study for research purposes, but a study to inform the work of AIM CCI and bundle development. Next slide, please. So as part of our work, what we found out was, and I think I should tell you that we look at both inpatient and outpatient data, quantitative data. Now, as you can see here, looking at globally, we looked at the years between 2018 to 2022. Now, that is what I've included in this slide, but we looked at a 10-year duration in terms of our review. And as you can see on this graph, peripheral vascular disease in terms of the rate takes the highest level of presentations per 10,000 hospitalization. That means birth hospitalizations. And if you look at this chart, I won't go into each and every one of these, but you will see that directly or indirectly, I will say about 60% of the factors here are impacted by hypertension and diabetes as a compounding factor. Several studies have been published that look at these factors that have shown the direct and indirect impact that this can have on both pregnancy and as well as the unborn child. So that is one of the reasons why we have focused on these factors or these comorbid conditions within that presentations and the rationale behind the recommendations that Sue will be talking about later on the global concept of the bundle itself. Next slide, please. So here, when we look at only the specific presentations, one thing I forgot to mention was severe maternal morbidity in terms of its classification by the CDC or its definition by the CDC. It's looked at both with and without transfusion, with transfusion being an indicator for hemorrhage. Now, as you can see here, in some instances or individuals with, let's say, chronic diabetes, based on comparing to the previous slide, have a much higher risk compared to those that do not have or did not have any indication for hemorrhage during hospitalization. And that goes to, let's say, individuals with just diabetes without chronic complications, hypertension, and those PVD is peripheral vascular disease. I'm sorry. Next slide, please. So in this slides, what we hope to highlight is mainly the overview of presentation. And this is not for the whole presentations or the whole factors that contribute to severe maternal morbidity, but specifically hypertension and diabetes. And when you look at these dynamics across the board based on regions across the United States, it has been increasing. So if you look at each and every 1 year between the 2018 to 2020, it has been increasing across the board, but you can see it is almost similar in terms of numbers, if you will. It's not significant in terms of the numbers between, let's say, going from the Pacific region to New England. The goal that we are hoping to highlight in this case is these presentations or these comorbid conditions impact mothers and birthing persons across the board in almost, at least by these breakdown of the regions in the United States, in almost every region of the United States. Now, it also shows that in some areas, the presentations may be lower, but also, again, this is part of the where I bring in my research hat to say, yes, it is possible that the population size or the birthing population size within certain specific regions or geographic regions may impact the outcome that you are seeing here. Next slide, please. When we look at the age breakdown, older populations, 45, and again, here I say 45 plus, but we did not go over, in terms of limitations, we did not go over 47. Older populations have a higher risk of both these severe maternal morbidity presentations as we see them individually, hypertension and diabetes, but also the likelihood of complicated complications that could be associated with that when we further analyze the data in a more granular fashion. Now, later on, I will mention that even though here I'm saying that at least the data is showing us that older individuals have a much higher risk of complications, I think one alarming issue that you will see in the subsequent slide is that it is rapidly increasing among young individuals, especially young minority populations. Next slide, please. So again, when we look at these demographic by race and ethnicity, as I'm hopeful that you have heard by now that among minority population, you will see, let's say the risk, as we can see here among Black and African-American population is 119 as a rate per 10,000 presentations. Now, one thing I would like to clarify with these numbers is that please understand that when we look at this by rate, the numbers may look very small, but look at it from the perspective of the birthing population within your community. Even though these numbers may be small, but also look at it from the direct and indirect impact these factors could have on the downstream health of the mother and of the child, not just from a clinical perspective, but on the social perspective as well. And you can also see here, when you look at the Native American population, the same trend happens. You can go granular where hypertension and diabetes is a similar trend that we are seeing. Now, one thing I also like to highlight based on this slide is across the board among all race and ethnicities, there is an increasing trend globally. When I say globally, generally from these data sets of severe maternal morbidities, both with and without transfusion for all population. So it is an issue that all of us need to take a continuous look at. Next slide, please. When we look at it from a social perspective, low-income populations. So again, even though this is very grouped by income demographics, low-income population seems to be having a much higher rate of presentation for severe maternal morbidity compared to a higher income population. Now, when you go even among the larger percentile, which is the 75th to 100 percentile, minority populations, when you aggregate the data by race and ethnicity, showed or seem to be having a worse or poor outcome than the general population. So again, this is by no means to say that the focus on severe maternal morbidity should be only on low income population. It is happening in each and every one of these categories, but it is getting worse, or it has not, there is no sign of improvement, at least from a trend analysis perspective, for minority population and globally when we compare across the board. Next slide, please. To conclude, as I've mentioned earlier, the most troubling, I think, part of our findings is that younger populations, especially among poor, rural, low-income populations, seems to be having a higher SMM compared to the general population. And more alarmingly, the younger and the idea of younger, healthy individuals is one thing that we are finding not to be true, because the risk is increasing, or the risk of SMM is increasing among these populations. So for us, it increases the need for us to look at effective strategies that can be utilized in the prenatal period to ensure that mothers and birthing persons are getting pregnant healthy and are maintaining that health status during pregnancy and in the postpartum period. So overall, I think this study has shown us the importance of taking a critical look at the data and ensuring that the data is informing the work that we do, and also aiding us, or at least guiding us, to focus on these comorbidities as an important factor that we can be able to focus on to mitigate on maternal morbidity specifically, and indirectly impacting maternal mortalities in our communities. This is where I'll stop, and I will switch over to Ms. Kendig. And if you have any questions, please put them in the chat and we will answer them later on. Thank you.
Thanks, Saanie. And I just want to acknowledge as I start, thanks to all of the AIM CCI team members who I saw on the call, because everybody had a hand in developing these bundles. And I think that is a really important point. This was a team effort. We have a lot of information to cover over the next 35 minutes or so. So just to give you a framework of what I'm going to do, I'm going to review the basics of clinical community integration, because all of the AIM CCI bundles are based on a clinical community integration model where we are looking to integrate our community partners, the work that the community-based organizations do, people with lived experience, et cetera, and the clinical components, so that we actually have a holistic approach to the care across the entire perinatal continuum. I'm going to talk a little bit about two pathways to participate in AIM CCI and take advantage of working with a group in terms of implementing the bundles. And then I'm going to review the bundle basics and talk a little bit about the chronic disease bundles. So all of that being said, let's get started. Next slide, please. First of all, for those of you who may not have heard have talked about clinical community integration. That is simply a model that provides an architecture to engage with patients and communities as partner in shaping healthcare and improving public health, rather than having only a clinical or hospital or healthcare provider focus on the strategies that we are using in communities. So it really forces an intentional strategy to connect those traditional structures with our community-based organizations and programs. And as we go through the bundle, or if you have already been part of implementing AIM CCI bundles, you'll see that that is really what we are trying to do, is make that connection with those traditional healthcare structures and recommendations, grounding that in the realities of the community. Next slide, please. And core features of clinical community integration, again, which really supports bundle implementation here, is that at least one step occurs in each setting. So when you look at the AIM CCI bundles, it's important to realize that not one of us can do this alone. We need to partner with people both within our institution as well as outside of our institution. But we need to coordinate those activities and reinforce and support all steps. Importantly, we need to share our resources and our knowledge of our community resources and share accountability for that through data sharing and common data collection, as Dr. Saanie talked about. And there are multiple examples of successful clinical community integration efforts in primary care already that we can really learn from. Next slide. And AIM CCI is here to help by fostering clinical community integration. If you go to our website, there is a clinical community integration pathway that will walk you through each step of clinical community integration that can be applied to your AIM CCI activities, as well as bundle implementation. Next slide. And it's important to note there are really two pathways to implement the AIM CCI bundles and participate in AIM CCI. The one that many of you are probably familiar with is the Local Maternal Safety Work Group, which is a community-wide effort where different community-based organizations, healthcare organizations, and people with lived experience come together utilizing a collective impact framework to implement bundles under the auspices of that local maternal safety work group, with the help of a lead organization that functions as a backbone. But this year, we also added the option of coming to the AIM CCI table and implementing these bundles as a single entity organization. And I really want to bring that to your attention because there is a lot to be done within single entity organizations. So for example, if you're a hospital that is wanting to branch out a bit, many hospitals are doing a lot of work on maternal mortality on the inpatient side. But on the outpatient side, those clinics and the nutritionists, social workers, et cetera, aren't necessarily included. By bringing the AIM CCI program to a single organization, that provides the opportunity to really think about how we are providing care across the continuum, both in the outpatient setting as well as the inpatient setting, and helps us think about how we better interact with our community-based partners that we need in order to meet those metrics. So if you're interested in a single entity organization opportunity, I'd encourage you to look a little bit at the website and reach out to the AIM staff. Next slide. So all of that being said, what is a bundle? It's nothing more than a small set of evidence-based steps that combines both medical and improvement science to achieve an improved outcome. So if you were working in a hospital, for instance, hemorrhage is something that is always concerning on the inpatient setting. So in order to address hemorrhage, you need to have a hemorrhage cart. You need to be able to get the blood from the lab fast, and so on and so forth. When we look to the community, or when we look to even transitioning between inpatient and outpatient settings, between inpatient and home and so forth, we have a lot more actors that we need to think about if someone is having a condition that could affect maternal mortality and morbidity. So when we work on the maternal safety bundles, our hope is that by thinking through some of those issues first and having all of our ducks in a row, so to speak, we are able to act quicker to get the person to the care they need sooner, to help them get to their material resources, social supports, whatever they need sooner, and hopefully mitigate the risk of severe maternal morbidity. Next slide. Equity is a key feature of the AIM CCI community care bundles. It is inculcated in all of the work that we do. Therefore, we need to have an eye toward equity in each setting. Next step. Next slide, I'm sorry. So that being said, we have several resources. Now, the AIM CCI bundles are really designed for the community. As I mentioned before, there are bundles that are very hospital-centric that have been in place for a while. Our bundles are designed for community, and they're designed to provide that bridge between clinical and community. If you go to our website, you're going to see 3 community care bundles already up. There is one for postpartum safety and wellness, one addressing maternal mental health and wellness, and another addressing intimate partner violence during and after pregnancy. The community care for the management of chronic conditions during pregnancy and community care for management of chronic conditions during postpartum will be released shortly. And because we have limited time today, what I'm going to do is focus on the community care for management of chronic conditions during postpartum, because many of the elements are the same. So the postpartum bundle is sort of a continuation of that community care management of chronic conditions during pregnancy. Next slide. That being said, now we're going to talk about these bundles, again, with an emphasis on chronic conditions during postpartum. Next slide. Why do we need a chronic conditions bundle? Well, overall, we're seeing women's health status pre and inter-pregnancy contributing to rising maternal mortality and morbidity. People are coming into pregnancy with pre-pregnancy obesity, pre-existing chronic medical conditions. Honestly, at this point in time, we're seeing people with chronic medical conditions like diabetes, hypertension, and other problems getting pregnant, whereas, several decades ago, we didn't see that as much. And of course, we also see chronic conditions or the risk for chronic conditions identified during pregnancy. Likewise, obesity is the most common medical condition in reproductive age women and birthing people, and it contributes to both long-term and short-term issues that can affect the person's health, not only during the pregnancy and postpartum, but throughout their lifetime. And so on. There is a 30% increase in the rate of gestational diabetes, with a larger annual percentage change between 2019 and 2020. So we're seeing more and more gestational diabetes. And we know that gestational diabetes increases the risk of diabetes being diagnosed during the postpartum period, as well as a shorter time for developing diabetes later in life. Likewise, preeclampsia and hypertension during pregnancy is associated with an increase. VTE is venous thromboemboli, is associated with an increased risk of heart failure, cardiovascular disease, stroke, blood clots, etc. So we know that if these conditions are emerging during the pregnancy, they are likely to affect the person's health throughout their life if we have a plan to assure that they are being followed, getting the care they need, and having access to information to help them stay as healthy as possible. We are setting them on for a healthier trajectory, not only during that first year postpartum, but throughout their life. Next slide. So the purpose of the chronic disease bundles is to assure that all birthing persons affected by diabetes, hypertension, and obesity have equitable access to those recommended preventive services, to both primary and specialty care that is congruent with their needs. And importantly, that we have a non-hospital focus on recommendations for outpatients for clinical providers, as well as other maternal and child health service organizations that are touching the postpartum person throughout that first year. We want to improve transitions of care. Many times what we know is people are maybe discharged and they're sort of left to make all of their appointments, fend for themselves in finding those specialists and so forth. We want to make sure that they are connected to the care they need throughout the prenatal and postpartum continuum and that transition to well or specialty care. And of course, the work is centered in racial justice because, unfortunately, these conditions tend to affect women of color more often than their white counterparts. Next slide. So all of that being said, let's move on to talking about the community care for chronic conditions during pregnancy bundle, and let's explore some of those elements. Next slide, please. First of all, if you are familiar with the AIM CCI bundles, you'll know that there are foundational elements that are the same across each bundle. If you have never implemented one of our bundles, you'll find these foundational elements. So even if you have implemented a prior bundle, it's important to review these foundational elements. We need to stratify our health outcomes by race, ethnicity, social determinants, and other identifiers, because that helps to identify root causes of inequities and helps to guide our actions. And I really want to point something out there, because I think normally we tend to look at clinical conditions, disaggregating the clinical outcomes by race, and that's a good first start, but we really have only just begun to start looking at those social determinants. And as an example, one of the programs that I work with is in a rural area of Missouri with high maternal and infant mortality. And when we would talk with providers, with community members, they always said, well, the problem is poverty. Everybody's poor. We have no resources. So that's really what's driving this. But when we disaggregated the data, looking at economics, we found that the Black population was 2 to 3 times poorer than their white counterparts. So that gives a lot of information as to who is more disadvantaged and who may need additional supports to meet their needs. You want to assess your local maternal safety work groups, and depending on the bundle you're implementing, you may need to think about adding members to your maternal safety work group. For example, if you were implementing the IPV bundle, you may start to think about, well, are there shelters for women who have been exposed to intimate partner violence? With the chronic disease bundles, maybe you're thinking about, we need to have some specialists. Do we need to start thinking about having a maternal fetal medicine practice? Telling us, helping with this bundle, what do we need that may not be in our current LMSW? And I want to point out that the equity work, next slide, please. I also want to point out that the equity work doesn't stop. So even though you may have completed the SAMREC, the assessment of equity capacity, and have completed the modules, you may want to go back and review that within the context of the bundle that you are implementing, and thinking about how chronic conditions are impacted by the disequities that you have learned about. So equity is always an ongoing learning process. You'd also want to go ahead and reassess your community resources list, because you may find gaps in resources needed to support the particular bundle that you are implementing. Next slide. And just a reminder that the AIM CCI website has a racial equity learning series and other supports to help support ongoing building of that equity capacity. Next slide. So after we've looked at those foundational bundles now, or those foundational elements, now we really need to look at the elements that are in the chronic disease bundles. Next slide. Okay, one of the first elements you'll see is providing education for all birthing persons and their supports on risks and warning signs for hypertension and diabetes that warrant contacting their healthcare provider during the first year postpartum. Most of us know about the CDC Hear Her campaign. That is a wonderful resource for learning about warning signs, letting people know that that is available. Some of our AIM CCI sites have implemented that with their patients and have had really good success. Some of the things that are really important about providing education, for providing this community education, is really thinking about health literacy and the cultural aspects of your community. A study of health literacy of postpartum materials regarding warning signs found that those educational materials can be really helpful if women can read, understand, and apply them. So you want to be looking at any type of education as to, is it understandable? Can consumers of a diverse background and varied levels of literacy really process and explain the key messages? And is it actionable? Once people can process and explain those key messages, do they know what to do with them? And when the warning signs were developed, when the warning signs modules for the Hear Her campaign were developed, they were developed with that in mind. Next slide, please. So the warning signs themselves were actually driven, this document was actually driven by a mother who had lost her daughter and grandchild to a hypertensive event during pregnancy. And this was her passion project, to make sure that birthing people actually had the words they needed to understand and talk about their risk factors. So in addition to the handout that you're looking at, people can go onto that Hear Her campaign website and dig a little bit deeper for information about actions that they can take, when to call their provider, and so forth. So it's a great resource. Some of the other resources are A1's post-birth warning signs that provide really helpful information for people around health education. Next slide. And the other things we need to consider in planning education and targeting maternal mortality is how this helps to enhance risk awareness and activate health promoting behaviors. Because birthing people's health-related decisions are really affected by their perceptions of respectful care, health literacy, as I mentioned, their personal health risk, and cultural or community differences in their lived experience. Home visitors, community health workers, doulas are especially important here because those are trusted professionals who have really been shown to be instrumental in providing information, emotional support that facilitates that client engagement with the healthcare system, improve behaviors, reducing stress, all of which helps to activate birthing people in accessing the necessary resources and accessing their care. So looking to our community members who are in those roles to really help support the education. Next slide, please. And again, AIM CCI has a variety of resources that can support staff development and community engagement, such as Planning for Pregnancy and Beyond, a free learning series to guide pre- and inter-pregnancy planning. So great for that first year postpartum. And the maternal monologues for community conversation and action, where people can actually hear the presentation of stories of birthing persons and their partners along their journey that is based on real experience. And so that's a tool to really engage with patients as well as communities about their own stories. Next slide. Another element is providing universal wellness education focused on individual needs after pregnancy regarding healthy weight and individual goal setting in the postpartum period. And we all know weight is touchy. Weight is extremely personal, and it's not about what we think the person should be thinking and doing about their weight, unless, of course, there are significant health risks, they're morbidly obese and so forth, which is a whole other conversation. But overall, we want to know what the birthing person thinks. What are her goals for her weight during this postpartum area and this postpartum transition? And we know that that is contextual and experiential in terms of how people make decisions regarding maternal child health and weight-related decisions. So utilizing motivational interviewing skills that most of you have been trained on is really an important part of having some of those initial conversations around healthy weight without stigmatizing the conversation and making the person feel ashamed of their weight and so forth. Next slide. The slides went away.
Okay, we may have, hey, Sue, it looks like we may have changed hosts. So
Oh,
let's see. Brittany, are you able to pull the slides back up? It says you're now the host. Sorry about that interruption, Sue.
no problem.
Great information though. And while we're waiting for the slides to return, I see most of the questions in the chat have been answered. And the one on the previous slide for the link, I think that was the link, Cammie, to the AIM CCI website for the resources page. You can also access that through the resources repository as a member partner. So in any rate, after the presentation, we will actually send out the recording with the slides information, so you'll be able to get it there. But it's simply the those materials that Sue talked about on the learning series, and maternal monologues are on the AIM CCI website for resources. So I'm going to ask if Iman is still on, or
I can go in and try and pull the slides up. I hadn't pulled them up for that reason. But I want to thank Brenda
Okay.
for describing VTE, but better than I did in terms of saying a fancy way to say a blood clot in the vein. So thank you for doing that. I appreciate it. Okay, I'm going to have to manipulate a little bit so that I can get to my slides. I'm sorry about this.
that's Sue, do you have are you a co-host to share?
Oh, I have no, I don't know.
Hi, Karen. Hi, everyone on the webinar. I apologize for the slides mishap. Iman's computer literally just shut off.
Oh, no. Okay.
Yeah, so she just called me to let me know. I don't have the email of the slides, but Sue is a co-host. So you
Okay.
should be able to share the slides. If not, let me know and I can
Nope,
fix it.
I think I can. They're just going to have to bear with me till I get to where I'm supposed to be. Can y'all see my screen?
Yes,
Yes,
we
ma'am.
can.
Look
Yep.
at us.
Look at us.
I know.
Virtual technology working.
Now, you all know what this
Yeah.
means, right? This means that it's all excellence, because anytime you have a technological mishap on the evaluation, it's all excellence. Okay, I've got control of the slides. There is an element in there about promoting informed decision-making relating to infant feeding by providing education and resources to support breastfeeding recommendations and the positive effects of breastfeeding on moms, including the association with maternal risk of cardiovascular disease and diabetes. There is a lot of emerging evidence of the protective effect on breastfeeding. There were systematic reviews done that suggest breastfeeding might be associated with a reduced risk of type 2 diabetes. There are systematic reviews showing that breastfeeding has been associated with lower odds of hypertension, and that lactation history and duration was really key to that association with the reduced odds. A lifetime lactation duration of greater than 6 months or greater than 3 months per child was significantly associated with lower odds of hypertension, and the odds of hypertension decreased with longer breastfeeding duration. That study was done in 2017, and again, and replicated after that. And most recently, there was another meta-analysis that also demonstrated a reduced maternal cardiovascular disease risk in women who had breastfed compared to those who had never breastfed during their lifetimes. So in addition, we hear so much about the benefits for the baby. It's important to talk about the benefits to the mom. And, you know, quite honestly, as a women's health nurse practitioner, whenever I work with pregnant and postpartum women, you know, there was always a time when they'd get to, you know, everybody keeps telling me about the baby, but I would like to do whatever for me. And I found that when I did my education and I talked to them about not only how something benefit the baby, but how it benefited their own health, we're sending the signal at that point that you are important as a person in your own right, not just because you're having a baby. And I think that is really an important message to send, particularly as we are helping women transition to well care. Okay, we want to train all staff on culturally appropriate application of the most up-to-date clinical guidelines regarding risks, warning signs, and interventions for hypertension, diabetes, and healthy weight during the first year postpartum using a respectful care approach. One of the things I didn't mention was that each of our bundles, in addition to having the foundational elements and then having the elements that are bundle specific, you will also see a list of resources. So when these bundles are released, you will also see links to ACOG guidelines regarding the comprehensive postpartum visit. There is more information there about risks and warning signs and interventions. So you're going to want to look at the resources for the bundles. I think this is where you can also leverage your experts within your community. If you are partnering with a health system, or you are a single entity doing this, having your clinicians present on those clinical guidelines so that everybody is hearing the same thing and working from the same guidelines is really important. The other thing I would recommend for staff education is that it be interdisciplinary. So don't just do clinician specific education and then take the CHWs and community health workers and have a separate education for them, but try to have some integrated education components so that everybody is hearing the same thing in terms of the clinical guidelines, because that is going to help to develop your plan as to how you're all going to communicate. And then if different groups have questions and they would like more information, those can be set up. But I always recommend that we start training everybody together so that they can hear the same thing. And that includes people who are answering the phone, front desk staff, our community health workers, and so forth, so that everybody gets to know each other and, again, hears the same thing. We want to assess our current community resources for healthy food access, considering cultural appropriateness to assist moms and birthing persons during the first year postpartum. And this is really important because moms who experience prenatal food insecurity are more likely to experience housing insecurity, financial strain, food insecurity, transportation barriers, and legal and social needs during postpartum. So when a pregnancy ends, those social determinants don't magically go away. But what may happen is they may prioritize the competing demands of acquiring food over obtaining preventive care or any other type of care. So looking to community resources such as fresh food pharmacies. Some WIC programs have added on the opportunity for a dietitian to go grocery shopping with people when they pick up their WIC resources immediately afterwards and have transportation to do that. So there are some innovative programs in community that can help people in identifying resources. We also want to provide community resources to support lifestyle interventions to support health. And usually exercise and healthy food is what we are trying to promote as lifestyle interventions, and stress management. Well, in an evaluation of the association of social factors with glycemic control in people with gestational diabetes, it was found that those who had satisfactory glycemic control actually had a lower BMI. They were more likely to be married, so have support, had a higher household income, and were able to exercise 3 times a week. They were less likely to have public insurance or reported history of mental health conditions. And those who were recipients of SNAP benefits or food stamps, actually, that was associated with worse glycemic control. So what this says to me is that resources to support healthy lifestyle interventions, there's an element of privilege there. And so we need to look at how we can make similar resources available to people who may not have that same type of privilege. It's easy for a healthcare provider to say, well, everybody can walk, you can just go walk. But if I'm living in a neighborhood that isn't safe, I really can't go to walk. I really can't go to the gym if I have no transportation. And I certainly can't get healthy food if I only have corner stores in my neighborhood. So really looking at how we can help to find those resources in creative ways to support healthy lifestyle interventions, I think, is one of the benefits of bundle implementation and all of us working together. We also want to assess current screening tools to assure they capture the social determinants that impact chronic disease during the postpartum period. I know many of you use the PREPARE tool, but the question would be, is that the best tool to use to really capture some of the other issues, like the link between adverse childhood events and chronic problems and so forth? right now, there is opportunity to really think about how we screen for social determinants of health, because CMS is requiring hospitals to report on the screening positive rate for 5 social drivers of health. This year it is a voluntary report. Next year it will go to mandatory, and the year after that it will go to looking at interventions to address the social drivers. So even though that's over a period of time, the screening that we do is becoming increasingly important in that clinical community integration space. Now, does screening for those big 5 tell the whole story? I would argue not, because the experience of living with low income and material hardship does increase stress and mental illness. And in fact, in one study, moms who were experiencing diaper need exhibited higher depression scores than those with food insecurity. So again, people trying to juggle what the priority is. So as we look at healthy food and as we look at resources to support health, we also need to look at how that interacts with other needs. Looking at culturally appropriate and respectful screening tools and interviewing techniques to discuss the impact of weight on chronic disease and so forth is, again, really important. In studies of pregnant person, qualitative studies have shown that people with obesity report feeling stigmatized, fearful of shaming. This is one of the quotes from one of the studies. It's like nobody thinks, why do you have a higher BMI? Nobody knows the background. It's just that they automatically judge you by their weight. And we really need to think about what is under that iceberg of weight. Genetics are a contributor, culture, food availability, the availability for healthy foods, the person's health status, whether it's physical or mental health status, that may limit access to or decision-making around what we eat and when we eat, exposures to trauma and self-perception, and many, many more. So just thinking about some of the ways that we may approach talking about healthy weight without stigma. There is a recommendation for comprehensive postpartum screening, screening to identify risk for chronic or emerging medical conditions during that first year postpartum is important, particularly since during the postpartum period, people who are dying from cardiovascular disease, that tends to happen after that first 42 days postpartum. So it's really important that over that year postpartum, we are really looking at how people are being screened and followed. And again, looking at the AIM CCI resources will link you to ACOG's comprehensive postpartum visit guidance that is really important in helping to shape that. Also, there's something called the Women's Preventive Services Initiative that makes recommendations for preventive services for women throughout the lifespan. There is a Well Woman chart that shows anytime you go for a Well Woman visit, it's stratified by age in terms of what preventive services should be available. And there are recommendations for pregnancy and postpartum as well. The good news is these are available to patients without copayment, coinsurance, or a deductible. But people are often challenged because if they aren't used to accessing preventive services, they don't necessarily know that. There are recommendations, again, for prenatal and postpartum care, so I would encourage you to go to that website and look at that. And the Well Woman chart brings together the preventive services recommendations from the Preventive Services Initiative, which is specific to filling in the gaps for women's preventive services. It brings together the U.S. Preventive Services Task Force recommendations, as well as Bright Futures for those people who are 13 to 18 years old. Likewise, screening for diabetes for postpartum is important. One of the elements is to ensure that every woman and birthing person with gestational diabetes receives a postpartum glucose screen within the first year postpartum. This is a recommendation from the Women's Preventive Services Initiative as well. And therefore, it is available to patients without cost sharing. Again, a really important point. This gives you the recommendations. The initial testing should ideally occur within the first year postpartum, and it can be conducted as early as 4 to 6 weeks postpartum. Likewise, every woman and birthing person with hypertension should receive follow-up according to clinical recommendations at a minimum every 6 months. In the immediate postpartum area, we need her to be followed more than that. So for postpartum people who have cardiovascular disease during pregnancy or those who are identified at high risk, they should have an early visit as soon as within 7 days after delivery for assessment of their well-being, their symptoms, and functional status. And a long-term care plan is crucial. If a woman is identified as high risk during her pregnancy, she should have a comprehensive evaluation at 3 months postpartum. So again, during that early and mid postpartum period, we want to see her even sooner than 6 months. And we want to, the final document talks about collaborating with local and statewide entities to ensure that women and birthing persons have access to equipment and community resources to manage their chronic conditions. Blood pressure cuffs. During the pandemic, the Preeclampsia Foundation had a cuff kit initiative. It's still ongoing. And I live in Missouri. I was really proud of us because we were able to secure money from a local foundation. And they gave us enough money to blanket the state during the pandemic so that everyone who needed a cuff could have it, because sometimes it's difficult to get them, even though the managed care organizations will supply them. The other thing that we know is that we had moms, particularly in our rural areas, that had very little access. There were several reports where people were able to report a high blood pressure and get into care immediately when they may have delayed that, again, because of the pandemic. So some of those blood pressure monitoring devices and having those available are really important. Many people want to work with their individual MCOs, Medicaid managed care plans, to make that happen. I would also suggest that you engage your state Medicaid agency, because they write those contracts, and letting them know if patients are having problems getting blood pressure monitors might be an important step in assuring that people have access. Likewise, diabetes monitoring systems, glucose monitoring systems, those are really important. Sometimes they are not covered and it's difficult to navigate coverage. So assuring that there is coverage in your area. The other thing I would suggest is looking at making sure the supplies are covered. We are finding that sometimes they are given a limited supply of the testing strips, and it doesn't last a whole month. So assuring that there is an adequate supply, and if not, again, working with those state Medicaid agencies to let them know that that is a problem so it can be rectified. We want to establish a plan to provide ongoing interventions to support the transition to primary specialty and well woman care. So at a minimum, she should be provided a discharge summary with her diagnosis, medications, and follow-up recommendations, as well as healthcare provider contact information for all of her healthcare providers, primary care, OBGYN, specialist, if there is a referral, say, to a cardiovascular specialist, mental health providers, whatever, so that it's all in one place. She should know the warning signs specific to her potential risk and when to contact the healthcare provider, as well as general warning signs, contraceptive considerations, particularly for women who have cardiovascular disease and diabetes. They may have special considerations around contraception, so we would want to be thinking about that in the care planning, as well as again, the provider name, contact information, etc. Implementing a culturally appropriate stage-based emergency response protocol for people presenting with medical symptoms or life-threatening conditions during that first year postpartum is extremely important. So being able to differentiate the level of risk. Is this something that the healthcare provider can just be called about? Do they need to be seen by the healthcare provider? Do they need to be seen that day, or can they wait a few days, or do they need an ambulance? And the best thing to do is work with your LMSW to figure out what works in your community in terms of that tiered response. But the other thing that I think is important is during that staff education, everyone is educated on the tiered response, and everybody is educated in everyone else's role. Because, for example, if I have a home visitor, a community health worker, a McVie home visiting nurse, a doula at the home, and there's an emergent situation and they're trying to get a healthcare provider, I want to make sure that everybody knows that that person needs to get through to the healthcare provider and that they aren't having to leave a message and hope that somebody calls them back. So think about all of that in your stage-based planning. And in order to establish a protocol that looks at closing the loop on referrals based on the results of your risk assessment is important. Some of you are using digitized resource and referral systems such as the Unitas platform or Aunt Bertha and so forth. And many times you can get a report that tells you not only what services are being used, but what services may not be taking patients for a variety of reasons, what types of things are being referred the most, and so forth. So this gives you an idea. Likewise, this will give the referring agency a notification as to when that loop is closed. So finding a way to track that closed loop referral is going to be really important as well. And finally, we want to assess and facilitate options for continuous insurance coverage during that first year postpartum and transition to well woman care. We're seeing more states adopting Medicaid postpartum extension for 12 months postpartum. And technically, those should extend all prenatal benefits postpartum, so their transportation, mental health, substance use disorder treatment, but that may vary by state. So it's important to know what your state is covering. Also, if you are an expansion state, it's really important to understand how people access those Medicaid expansion benefits. In some states, they are just rolled into postpartum expansion benefits, but the patient may not know. So they may have problems, but they aren't coming in because they don't know or they don't think they have insurance. So how are patients being notified and educated that they actually have Medicaid extension for 1 year postpartum, and how do they utilize that? How are they transitioned from it? Is it something that the healthcare provider needs to put in place? Do they need to call the Medicaid agency, or is an automatic rollover? So advocating for continuous coverage is exceptionally important. And I know we are a bit over time, but if there are any questions in the Q&A box, I'm happy to stay and answer those, or we can send that out. Karen, how do you want to handle this?
Yeah, I think that all of the questions that have been put in the chat have been addressed. So we are recording this, and these recordings will go out to anybody that's registered. If you have any additional questions or comments, please feel free to contact us at aimcci@nationalhealthystart.org. We are anxiously awaiting the release of these bundles to share, and they will be publicly available on our website, aimcci.org. So I just want to say thank you so much, Sue and Saanie, for a wonderful presentation today. Great information. Lots to think about, but we are happy to be here as a resource for anybody regarding these issues. So thank you all so much. I'm not sure if Iman made it back on or if there's anything else. Oh, okay. So I'm going to turn it back over to Iman to wrap us up. Thank you.
Thank you so much, Karen. And so I hope that everyone has a great day today. And thank you for being here.
Thanks, everybody.
Awesome. Thank you. Bye-bye.
Bye-bye.